6:30 or 4:30 your time.
Oh no! Oh dear! Do we lose? So we lose some people. That's
I
unfortunate.
emailed everybody. Hopefully,
Yeah. Well, and hopefully you'll catch some like on the recording, so people just don't watch it live.
All right, there we go.
Mm-hmm.
Okay, Joshua, what's up?
Oh, well, there's always something going on in the clinic. We had an amplifier go down because a kid smashed one of the cords and broke one of the isolate USB pins, and so then we got.
You got to push in and turn. Push in and turn.
No, don't do that. You're talking about those little, yeah. The gosh, if anybody's watching, he's joking about these. These are like twisting. These is like they'll destroy them. It's so terrible. Worst advice ever. Though I would say that every employee destroys at least one. Destroys at least one thing. It's just how it goes. It's part of training.
Well, it's more than just destroying one thing. Is when they keep the stuff dirty and all that paste gets in there, and you get a bad signal. And
it's also funny because every employee has their own thing that they're bad at cleaning or something. Like don't want to criticize anybody, but like they're really like good at what they care about. But that has like variability between people, and so when they share rooms, they're kind of horrified at what the other person will not, will not clean.
When the next tech comes in, who's a neat freak that's taking over for a slob, then you got to deal with all that.
Yeah. I've never really noticed like that anybody is like there's nobody that's like super, super clean about everything. Just nobody. Like everybody's got something that they're not like super honed in on. It's okay.
Can we get those Tesla robots to do it?
Yeah, very likely. Very, very possible. I think you're a couple of years away from it, but they'll likely follow you around and watch you for a couple of days, and then just do the routines. Yeah.
All right, I'm putting my order in now.
Yeah. Yeah, it's all machine learning, and the thing is that the big company, they're going to want the data for machine learning purposes. It's, they've already gobbled up all the virtual world data. Now they want the real world data. So while the machine is learning your patterns in life, it's also training the larger AI model, which is what they want it for. So they're a machine learning company. The company that sells you the robots is actually trying to build a larger algorithm for the rest of the world.
Which bucket will all that data go into? Proprietary data.
We're going to share not like data you can sort through. It's not like, at least not from what I'm aware. I have people I could call and ask these questions to, but it's not necessarily like data you can sort into. It's kind of like a person. It's grown, and you can't necessarily like rifle through what it's learned necessarily. It's complicated. But yeah, it'll be whatever AI system it's trained on. So if it's Tesla robots, it'll be either Grok or something adjacent to Grok. Yeah.
Well, the price point of those things, I want to say, is $30,000, which means that it's $50,000. But even so, for a full-time employee for a year,
yeah. Even if it moves at half the speed, it's still, we'll have your bakery all ready to go in the morning. Anthony's here.
Hey, Anthony, sorry about the wrong time.
Oh, I'm sorry. Was there a snafu? I've been so busy today. I didn't see.
Oh no, there was no snafu. Everything's fine.
Okay, good. Yeah, it all worked out. How are you guys doing?
Good.
Appreciate the invite.
Joshua is talking about Tesla robots. They're going to take over for techs. That's what he was just telling me.
Probably not. That would be wild, though. I hadn't thought about that application. I was thinking about more simple things like cleaning, having them actually do the tech work. That'd be interesting.
I just saw a video of Chinese robot boxing, and that was pretty interesting as well. Yeah.
And the robot doesn't lay up.
Yeah. Well, I was thinking about that. I put up a story the other day about a really intelligent kid that Josh commented on. Did you guys happen to see that, or
you did? Yeah, it's good.
Remember that?
Yeah, I think you have a point. I think I was like wondering if it was going to scale into intelligence. You talked about a 2-year-old that can count to 10 in like, what was it? How many languages?
Yeah, I think I said like 50 languages or something ridiculous.
Yeah, rolled over at the 5 weeks. I've heard of these cases before. Like I had a professor's daughter who could do these kinds of things. And it did scale into intelligence, like into age. So her intelligence did scale as she got older. I forgot what her IQ was, but it was very high when she got older.
Wow. I think there can be some, and you were correct to say it doesn't necessarily manifest in adulthood or help, because for instance, I've heard of a condition called hyperlexia. And so kids that read at an early age, I think there might be a little bit more criteria. I should be careful, but yeah, anyway, kids with the condition hyperlexia, I think on average, they actually are, have diminished cognitive ability. They say they often, they can read and they know their letters, but they often don't understand what they're reading. And so the majority of them have cognitive impairment of some kind.
Fascinating. That's an interesting connection.
Yeah.
I know we taught our kids sign language when they were really little, like 6 months or older. And kids, little ones, they have a phenomenal ability to learn sign language. And they can get their needs met very, very, very young. And complex, they can learn, hundreds of words, but that doesn't scale into intelligence. And so you'll have a kid who will know very complex signs and be able to communicate very sophisticated wants and needs at like 8 months old. And people will be like blown away by that. And they'll think your kid's really bright, but it does not scale into intelligence. That's not what that is. So it helps lower anxiety.
What anxiety? Sorry, I missed that.
Oh, it helps lower anxiety, but it doesn't equate to intelligence.
Is that reading, you said, or lowers anxiety, or which thing? Speaking?
Being able to communicate. So being able to teaching your kids how to communicate at an earlier developmental age using sign. So you can teach, basically babies to communicate more specifically to you using sign. You can do that, and they'll learn it. It's an early developmental model of language for them. And
did it help, you felt, I guess, overall?
Only in communication and getting needs met, yes.
Getting needs met. Okay.
So it lowered anxiety. You can think of it that way. They had less. They were less anxious as kids, but it doesn't actually make them smarter. And they do look smarter, so people will think they're really brilliant kids, but that's not.
Wait, how do you look smarter?
Well, like if you have like a 1-year-old that is using sign and asking, or even younger, asking for things that like water, or asking for juice, and saying no, I want juice. He's very, very sophisticated. It's just interesting, and when people see that, they get startled. They're a little surprised by it.
I do recall a mother telling me that they had done that with their child, and that it could almost creep out other parents.
Yes.
But I will say their child's intelligent, but it's not like orders of magnitude more intelligent, but she is, probably gifted and things like that.
Sure.
I was going to say, the research is saying, so basically all the reading bodies, so they actually don't recommend that you teach children reading till like 5, 6, 7. And that's actually how Europe does it. And I'm sure there's a balance, but one of the things they said is that in youth, what children should be focusing on is their social and emotional skills.
Yeah.
And that's when the brain is forming. Yeah. So, so that's, as far as I'm aware of, that's what the research bodies say about reading teaching. It's a little counterintuitive, because every parent's like, my kid reads at age 2. They got a big leg up on you, right? And it's like, the research doesn't seem to show that. So, yeah.
I agree.
Wait a minute. What about those, what do you call them? The dragon moms? Tiger moms?
Yeah. Their kids are more anxious and depressed.
Yeah.
So that's a real thing. And by the way, just having, one of the things I said to Josh is the kid is going to be more at risk for anxiety and depression. So high IQ people have an increased risk of anxiety and depression.
Yeah.
And by the way, I don't know if you have any Asian friends, but they'll tell you like, oh yeah, very strained relationship with my parents. They're taskmasters. I mean, I have had personally Asian friends tell me several times, yeah, I wasn't a doctor, so my parents think I'm worthless. and they're talking to me in their 30s. These are 30-year-olds telling me this. So yeah, I'm not interested in that model. I don't have kids, but were I to have kids, that's not probably what I'll be pursuing for that reason.
Yeah, complicated stuff. When I was in the military, I had a few buddies who just joined the military to get out of some sort of family expectation track.
Oh.
And I don't claim to understand that at all. It seemed very complicated for them. But getting into the military was their way of trying to create another option and they didn't know if it was going to work. I just remember them like, yep, I'm going to try this. going to try and create a new path because they didn't see a workable path forward with the current expectations, which is
interesting.
When I think like Western, typical culture that I was brought up in, they're a little bit too whimsical. Follow your heart is not a great model either.
Well, they say the helicopter parenting is bad, and I'm sure though there's going to be an excess on the other side. They say the helicopter parenting, it's not just doing things; it is a form of over-involved parenting, and that has its own downsides.
Yeah.
But I think I've heard like the best parenting. I think they call it. It's being more like a facilitator. That seems to have better outcomes that I've heard. Like, oh, my kid is interested in this. Let me nurture that.
Yeah.
Versus, but obviously, I know parents with children that they're going to respond way better to one of those styles. Like kids can be very different. I know I've seen that already. So
I've always had the metaphor of you don't want a forest because it's chaos, and you don't want a factory because it's stifling. You want a garden.
I like it.
A garden means you got to weed, but you also got to let it go.
And you have a bunch of little ones, I think, Josh, or
yeah, I've got a 2-year-old and a 4-year-old and a 9-year-old.
Oh wow!
I'm still in
Wait, 3? I thought it was 2. Holy crap!
No, I got 3. I got third one.
That's congrats. And I'm real. Have you looked into have you ever done neurofeedback with them? Just curious.
Yeah, sure.
Oh, interesting.
Yeah.
Were there any good stories or approaches that and obviously that's up to you to share. There's no pressure.
Well, I don't have a huge amount of expertise in mapping our really little ones. If I was trying to map a really, really little kid with complex issues, I'd probably send the data off to like Rusty Turner. Rusty is a board certified pediatric neurologist.
The kiddos.
Yeah. But I'm not afraid to do a little bit of like infralow or ISF kind of general approaches with my little kids. And especially when they're little, I do a lot of ISF in my clinic, but with really, really little people, I've had really good results with ILF with my little kids. And I was doing ILF maybe when I first started doing neurofeedback like 10, 12, 13, 14 years ago or something.
Yeah.
And you don't do a lot. You just do a couple of sessions and you just kind of notice, some significant improvement. What's happening there? Not sure. It has something to do with like glial networks. It's a bottom up approach to brain training. It's a lot broader. You see influences on the triple network theory. You're not necessarily approaching it from a neuromarker standpoint, though. The phenotype model does help you know when it's going to be useful or not. I think that's a controversial thing to say, but that's how I feel.
I like that.
Yeah. Okay. So, yeah, I do have some strong opinions, but I don't like voicing them off into the internet because I feel like I'm gonna get angry people coming at my door.
Nobody's watching, Joshua.
What's that?
No, nobody's watching. Don't worry about it.
Nobody's watching this. Just speak freely. That's right. You won't get any angry letters or voicemails or people knocking.
So what is the best thing for first-time parents to do with their first-time kid in the crib to keep their put a mobile up? Is that like the simplest, easiest thing to do to?
So here's the thing. I think for the first 6 months, you got rules like breast is best, and there's nothing they could ask for that isn't appropriate for them for the first 6 months. There is a point around 6 months ish where you really need to look at sleep training. I know it's a controversial thing to say, and a lot of people, I'll get hate mail for that one too. I was opposed to it. I didn't like the idea. My wife asked me if I would be willing to support her in sleep training. She didn't ask me what I thought about sleep training. She asked me if I would be willing to support her. And I said yes, because she asked me to support her, not because she asked my opinion. That's exactly how it went, Pete. That's exactly
how it goes. That's
yeah,
exactly.
so I thought about it. How technically she didn't ask for my opinion; she asked for my support. So I said yes, I'll support you.
Yeah.
So she wanted to do this really intensive sleep training where blackout windows. So the mobile doesn't matter because it's completely blacked out. The child is allowed to be moderately distressed for 10 minutes, a minute of soothing, 10 minutes of distressed, a minute of soothing, 10 minutes of distress, a minute of soothing. If they're distressed, another 10 minutes and they don't fall asleep, you can get them up and it's a failed nap. There's some similar protocols for bedtimes, you know, but if you're going to nurse them, you turn the lights on, you nurse them in the light. So they're not allowed to fall asleep to nurse. Nursing is to nurse, not to be pacified. And so you kind of detach the associations of self-soothing on certain mechanisms like nursing, and you reinforce and give them windows of opportunity to learn distress tolerance. And it was an extremely painful process as a parent to allow, but it did give you boundaries. Like you're going to set a timer and you're going to go in and soothe them. And it did set limits to those iterations so that it would actually stop. What was amazing to me was that within 48 hours, every single one of my kids was sleeping through the night perfectly and sleeping through their naps perfectly. And some people will argue that that's traumatic, but I think it's pretty obvious that those kids have a much stronger sense of autonomy, which I didn't expect. That there's a sense of like really self-autonomy that I didn't really, and developmentally, there is that Erik Erikson's model of psychosocial development, autonomy versus shame and doubt. It is appropriate at that age. I think it's 6 to 2 or something, or maybe it's 6 to 2, I think. But I do think people need to look at sleep training because 1, the health and wellness of the family, and 2, I was surprised at the psychological benefits that I observed in my kids. I didn't expect that. In fact, I was opposed to the whole idea until it worked.
And that says something that you came in opposed. I do want to, there is, so yeah. Some of the things you said, so for instance, you said detaching their sleep drive from their comfort drive. And so that was making me think already. I was already thinking about attachment theory. And then you mentioned autonomy. And so there's a lecture that you can listen to on attachment theory. It's a psychology professor at like University of Texas. And he says, have you guys ever been in a restaurant and suddenly a little kid walks up to you and they're all happy to see you and they're talkative, they're friendly and open. And they're like, hi. And you think it's all cute and you're like, where are your parents, little boy? And they're kind of cute. He goes, that's not cute. They're avoidantly attached, and that will be a factor in their adulthood. And that is actually how avoidant attachment was discovered. John Bowlby, the psychologist who generated attachment theory, he found that the children that were comfortable being away from their parents in what's called the strange situation task, where the parent leaves the kid in the room alone with a researcher, he found out that those kids had essentially, it's further research, he called them avoidantly attached. And it's since been found that children who are avoidantly attached, who don't mind when their caregiver leaves, they tend to have more trouble connecting in intimate relationships.
Sure.
And so I don't have research, and I've looked into sleep training. I don't have research for you that says sleep training results in avoidant attachment.
Sure.
In fact, if you Google that, you'll hear it doesn't do anything bad to the kids. But none of those studies looked at anything more than a few years out from the sleep training. I think the latest I've ever seen was 9. In other words, there's no study I'm aware of that looked at sleep trained children and looked at their attachment styles as adults. And so until I see that study, I'm going to be worried. Now, I have the luxury, I don't have kids, and I get it.
No, absolutely,
So I understand.
And I think that the parent that's going to get a lot of things right is going to be the one that fusses over it and looks at all the ins and outs. And whatever you reside on, whichever end of the fence is going to sound weird. It may not matter in the grand scheme of things because you are the kind of parent that fusses over all those things. There's actually some fascinating statistics. I think my I don't know if I should throw that one research out. My own sister came to me. My own sister is an anti-vaxxer, and she had this study that she showed me. It was like 800 kids had like much lower developmental problems. The ones that weren't vaccinated, and the ones that were vaccinated had more problems. And it was like, okay, this is compelling data, but is it correlation or causation? Which is my criticism of it. And not that I'm sure I'm right, but it is a question of correlation versus causation, because you had hyper conscientious parents who didn't vaccinate, which means they're doing a lot of interesting things differently. Okay. And in that conscientiousness, what they get wrong or get right, they're a conscientious parent, and that is generally a really good thing. So there's like, we'll say a heavy bonus associated with conscientiousness.
So conscientious parenting, and in other words, their human behavior is complex. Lots of things the parents are doing may matter. We don't know which ones are key. I was going to say also, to temper my comments, I think neurofeedback can help with a lot of this. I have mentioned to you guys recently, like for instance, my friend's son, who they have had, emotional and behavioral problems, and it's created a big problem in the home. Doing neurofeedback, specifically broadband inhibit of FZ is what they did. That's when all the change happened. Suddenly the kid is better behaved, expressing love for his parents, and the house is more harmonious. And so I do think and to me that speaks to attachment and connection. And I've seen attachment drives change under neurofeedback. So that I wanted to bring that up to lead into. Well, I'll let Josh respond to that, and then I have another question. Yeah.
Well, and then I having done the actual sleep model that I mentioned, kids go through more distressing experiences than the 10 minutes of moderate distress that you have kind of alternating with periods of soothing. So it's like we're not talking about a terrorizing experience for a child, It doesn't quite rival kind of the regular things that they have going on pretty regularly. Like I would say that if you looked at like my kids' childhood, they had far more traumatic experiences that related to going to the doctor. They had far more traumatic experiences relating to hurting themselves. They had far more traumatic experiences related to getting lost, and not being able to track and find the parent. And so they're pretty mild to moderate, and they're pretty limited in scope, which is kind of why I'm like, okay, like it's not too bad. Like if it was weeks on end, I'd be more concerned, but it was 48 hours or less for each kid over the period of like 1 or 2 naps.
It was a fairly fast transition. That's cool.
Yeah, I mean, kids learn fast. That's the interesting thing about kids. They learn fast, and you're actually giving them like the idea is that window of what's the word for it? That window of learning. There's a term for it. I'm not remembering the actual technical term for it. The idea is you're only trying to stay in that window of learning, and that if the distress gets too high or too long, you intervene. So you're kind of not letting them get too upset. There's a Goldilocks zone basically that you're trying to stay in for learning.
Anthony, you jump in. Oh, hold on. We got an order up. Jehan.
I'm not familiar with Axis 2 diagnosis. Josh may know. What's that referring to?
So personality disorders.
Okay.
Yeah. So neurofeedback, there's a lecture I've got down here somewhere, recorded lecture, CD, on someone giving a lecture at ISNR on personality disorders and its utility. I don't know if they've got a lot of research on it, but basically anecdotal clinical response or clinical feedback, which there are lectures and forum representatives who've talked quite a bit about this, that the ability to increase distress tolerance is phenomenally critical with these populations, because what they have to do is something like accept that they're something like emotionally colorblind, that they are missing a key ingredient of what it's like to have a real healthy relationship. And they need a sounding board in a person that they can use as a baseline, like the therapist, to help build that back. And it's actually excruciatingly painful for them to do. And it's their ability to tolerate that across time is going to determine whether or not they're successful. Neurofeedback protocols that increase distress tolerance is the name of the game. And it becomes incredibly useful when you use it that way.
Yeah. Okay. And what patterns are resulting in the reduced distress tolerance often? Do you know offhand or recall or?
Yeah, I mean, I'm a big fan of the phenotype model, obviously. So you want to figure out what's going on with this person. Like if you got a whole bunch of spindling frontal beta, you kind of want to get that down. If you don't, you don't. Yeah. So like that protocol does not work for someone who doesn't have that. And so it matters a ton what's going on with you. And there isn't protocols that fit symptoms, because Jay said this really well the other day on a forum. If protocols worked based on symptoms, then the diagnostic manual wouldn't be garbage. He's like, yeah, that's fair.
Yeah.
So like, you know, we could have built effective treatment plans using the DSM, and they would have all been great. That's what he meant. You know,
I think that's what he meant. Because I know he's big on that, but I mean so for instance, we know that certain phenotypes are associated with certain, you know, like for instance, ACC failure, we know that could be giving you OCD, it could be giving you ADHD. We know that that's a majority. So we know a majority of ADHD kids have one of those ACC failures.
So like there are diagnoses that get really simple, right? Like PTSD is kind of like one thing, right?
Yeah.
And OCD, with very few exceptions, is kind of one thing. But you kind of want to figure out what failure mode it is in the AAC, right? The anterior cingulate. You know, but other than the fact that there's a few different failure modes, you know, there's a failure mode going on, right? So you want to figure out what flavor.
You still have to know which one. I will say, well, anyway, to Jay Han's question, I want to say too, well, it's still similar to Josh's answer, but I think Jay has talked about, so the Axis 2 diagnoses, I think that includes narcissism, but if it's anything like cluster B, which is things prone to like drama and extreme behavior, so narcissism, antisocial personality, and let's see here, borderline. Okay,
they added codependent personality disorder too.
What'd you say?
They added codependent personality disorder.
Interesting. Okay.
Yeah, I think so.
I'm not familiar with that one yet. So, Jayhan, Jay has said on here, essentially, it seems like a lot of those are associated with ACC failure or frontal slowing. And I think some of the papers will show that. But essentially, Jay has described narcissism as addiction to status. And so addiction is often correlated with theta, beta, or alpha in the ACC, in the anterior cingulate. And so I have found, I have seen, because if we think of these diagnoses as a spectrum, to where all of us are maybe just a tiny bit narcissistic, you know, nobody's probably zero of any of these things. I have seen those behaviors lessen. So people get more empathetic, which is lacking in narcissism, and they get less grandiose as they have addressed their phenotype, which is what Josh was talking about, is finding out which of the common patterns have gone wrong in your EEG that were identified by Jay Gunkelman and Lunt and Joy, who's been on here, and Johnstone. And I have seen people improve from personality disorder-like symptoms when they do this style of treatment. I can't speak to others.
Yeah, I agree.
So, on the attachment theory thing, while we're waiting for another question, there was a guy named, or on the sleep training rather, there was a guy named Rudder, and he studied infants in the Romanian orphanages.
Oh yeah.
For some reason, there were a ton of Romanian orphans, probably maybe still, but at one point, and this guy Rudder is famous. And he visited the orphanage and he noted something interesting, which is that none of the babies in the orphanage were crying. And he asked the nurses, why are they not crying? And the nurses said to him, this is very famous. They said to him, well, we're so understaffed that we can't come very often when they cry. And so they just stopped crying.
Yeah.
And so he later went on, I just looked up what happened to Rudder's kids that he studied. And he found out that even the Romanian orphans that were adopted by British families, they showed more frontal abnormalities compared to normal kids. Now we could say, oh, well, like Josh has said, there are other factors, you know, raised in a time of war, raised in potentially they were in poverty, fewer caregivers because these nurses were understaffed. But Yeah, for me, intuitionally, I can't tell for sure if sleep training is going to interact with all that. Right. But that there's other data saying it's good, and the data generally does say that the kids are fine.
Well, and I would also add the counterpoint of the amount of sleep that they get is phenomenally higher than it was before the sleep training.
That's an important
and it's like that's hard to like that's a cherry on top. It's like, whew, not just the parents' sleep, but the kids' sleep goes up. The kids sleep a lot more because they're not waiting for a criteria that they don't need anymore. Like, I've got to have this adult, and I've got a nurse, and I've got to do this. It's like, no, they can just roll over and go to sleep. So our kids typically slept 12 hours a night, and then would take two naps, 1 2-hour nap and 1 hour nap. And they did that until they're about 1 and a half. And they go down to 1 nap, which is about an hour, maybe 2 hours. And they still sleep about 12 hours until they're about 2-3 years old.
Wow.
And they drop the nap. And I think at about 3 or 4, they're sleeping about 9 hours with no naps. Yeah.
Yeah. A friend that had a child recently, I was learning from them, kids need a lot more sleep than I realized. They're really, I think they want them to have like 12 to 14 hours until they're like, I don't know, 8. I mean, it's really, if they're not going to bed by 8 or 10 at the latest to get ready for school, apparently that's associated with bad outcomes.
Yeah.
Ideally, you want to get them like 12 hours of sleep, it seems like.
Yeah. And it's amazing, but they'll happily sleep that long. It's a little surprising, but they will. And the baby will get up to nurse until they're about 1. They'll get up to nurse once in the middle of the night. But that's about it. Like 6 months to 1 year old, they'll get up once in the middle of the night to nurse, and that's it.
That's great. Well, I'm happy it's gone smoothly for you. I will say, I think myself.
I don't know. I think it's called Little Sleep Trainer. I think I don't know. I would not choose to go forward with a program that you weren't comfortable with, and I do think that you want the lightest hand possible, because Anthony's concerns, talking to the audience here, is valid. Like you want the minimally invasive, the most minimally invasive amount of imposition possible to teach your kids that autonomy. So I think everything you say, Anthony, I agree with you.
Yeah. And thanks for letting me share those. And I'm sure, and they've got you and they've got their mom, and you know what brains are supposed to be looking like. So they got that benefit there.
All right, so we don't have any questions. That means I got to drum up some. I got a couple for you, Joshua. Let's talk about the Binky, the pacifier.
My kids never got into that. I don't know what that means. Not one of them. None of them did. I had one kid that sucked his fingers for a little while until the dentist told him he shouldn't do that. And my 4-year-old's really odd. He was like 3 or 2 at the time, and we kind of told him we didn't want him sucking his fingers anymore, and he got a little upset. And I don't know what we did. What we asked him, like, if you choose not to suck your fingers, I don't know what it is we tried to offer him, but we tried offering him some incentive, and he just did it, and he broke the habit, and it was really quick and really easy. It was like, okay, it wasn't a big incentive either.
So I just pulled it up, and what the research says, I kind of guess, is that children who are not breastfed are more likely to enjoy a pacifier, which kind of makes sense. This is have you ever heard of reflex training, or not reflex integration, Josh?
Yep, absolutely.
Yeah. There's a lot of schools, for those who don't know, and Pete, I'm new to this too, but there's this idea that sucking on your finger is kind of a reflex. It's an innate behavior that all humans have at some point. And sometimes these things get delayed, or they get interfered with. And so going to an orthopedic therapist, they're occupational therapists. Occupational therapists often do these. They try to help them. So for instance, there's certain reflexes, and they need to go in a certain order. So they'll actually put the kids into those positions, be it a crawling position or a sucking thumb position. And there's actually a paper, if you just look out sucking in the EEG, there is a paper that shows that when children were fed and they had to suck, their EEG amplitude lowered throughout the frontal regions. It seems like it's literally balancing them. We've got a question here from Hida Manaza. Is sleepwalking in kids serious? Can we do anything with? Well, Jay would love that one, but Josh can go for that one.
I think I can over the years of training under Jay, I think I can manifest him a little bit. When kids are sleeping and they don't act out absolutely everything that they dream, they do so because of something called sleep spindles. Sleep spindles induce essentially a appropriate paralysis state when you're asleep. When that's used appropriately, when that mechanism is appropriate, it's normal, it feels normal, and we dream, and our body does not act on those dreams. That same neuronal cluster that we call sleep spindles, when you're awake, they fire in a similar rhythm that we call the sensory motor rhythm. If the sensory motor rhythm is slightly underdeveloped, even in a non-clinical way, you can see things like sleepwalking. And so, yes, neurofeedback can do something about it. It can be hard to train a sensory motor rhythm that is a little underdeveloped because it's already a very small mechanism, but it would be worth trying. It really would.
And have you done that in a younger person before, Josh? Or
absolutely, yeah.
How young, or do you think it's like what if you mentioned it can be harder with an underdeveloped rhythm? What issues might they encounter, etc.?
Well, so when a rhythm is smaller than it's supposed to be, it can be harder to train just because it's closer to the background noise of the amplifier and the background noise of the brain and the artifacts that are not real data. So basically, you're kind of running into contamination when you're dealing with a much smaller thing that you want to train. So you're kind of running into less accurate training. Does that make sense?
Okay.
So if I'm going to train something smaller, I'm going to be running into just less accurate training. And less accurate training could mean a higher failure rate in training. So that's not great. And so the sensory motor rhythm is not the largest. It's not like alpha. Alpha is huge. Like you could have a much smaller alpha wave and still do great in training. But the sensory motor rhythm is very small. It's very hard to see with the naked eye. And so it getting smaller is not great. So, cats did extremely well in Barry Sternman's study, and it wasn't even necessarily trained on purpose, but it contaminated the NASA study. And, the cats were resilient to rocket fuel in 1964 when they injected them with rocket fuel. That whole thing with UCLA Davis and NASA, because cats actually produce a larger sensory motor rhythm ratio to background rhythm than humans do. So ours is actually a harder learning curve to catch than in cats, which is a little unfortunate. So it sounds like, it's super easy. Like, it's actually easier to train in cats. We train other mechanisms very, very easily. The sensory motor rhythm is like, 80% or so seem to train it very well, and 20% seem to be like non-learners. So it can be hard, and it's still worth trying. Like human beings are worth trying to fix, And there are backdoor approaches like infralow and infraslow. Sometimes I've seen that work as a bottom-up approach, which is it's still experimental, but I would still try it if I was backed into a corner, because it can propagate larger sensory motor rhythms and do really interesting things, but it's still experimental as far as I'm concerned, as far as I understand. And if I had a non-learner, I would get consent for that. I would have informed consent and talk about those other approaches, because it's really, really worth continuing to try if you can. And it's fairly safe. So, if you're having decreased the sensory motor rhythm and the sleep spindles, those are like fully developed by, I believe, the age 2. So if you're having someone sleepwalk at like age 3, 4, 5, 6, might be a problem. It might not be obvious that it's affecting them in other ways, but it could just be affecting them with like attention. And so what do I get out of that besides sleepwalking? It could just be attention, but that might be good. If it scales into adulthood, that might be positive to try to get that.
She's got another question here. Hida does. If the child sleepwalks, that explains sensory problems when they are awake too? Question.
Sensory problems when they are awake too.
I wonder if she means like sensitivity, sensory sensitivity.
Yeah, so it could. It just depends on what's going on in the brain, I suppose. The problem with the sensory motor rhythm is like it could influence so the sensory motor, and here's the reason why it's hard to say what it could or couldn't do. When the brain is growing in utero, what are the first cells in the brain to develop? Guess.
Brainstem, thalamus.
No, it's sensory motor rhythm. The sensory motor strip, and it all folds out like this. So you get your somatosensory cortex and your sensory motor cortex, and it just unfolds. It grows like that. It blooms out on both sides. And so like, it just kind of everything unfolds from those two strips. And so, it's just kind of connected to everything. So could it play a role in sensory integration? Yes, maybe Jay could look at a particular map and theorize why. Likely, he's pretty good at catching, expression of symptoms from looking at just data. The rest of us are, hoping to catch up to him by the time we're his age, which is an interesting challenge.
So 8 years old, Hida was saying.
Yeah, 8 years old. Yeah. It feels like something that I would want to try to find some support for if it was my kid. Again, there's nothing medical, but I like to think of my kids like pretty holistically and preventatively, and I would want to look into what I could do to try to support that kid. And if it's a sensory motor rhythm that they need support of, which will automatically support that sleep spindle, which is what they need. You don't know that's what it'll do, but it probably will. That's what we've seen it do in other cases, is the enhancement of the sensory motor rhythm we know will support the sleep spindle, which can stabilize sleepwalkers. And so, pretty useful. There's versions where there's sleep architecture problems and the sensory motor rhythm's not quite the problem, and we don't really understand how that plays out. But like if they did a sleep analysis at a sleep lab, maybe they'd see something really complex and really interesting. And then we'd still probably try the sensory motor rhythm training, but we wouldn't know for sure if that would work. Does that make sense?
Yeah. Okay, next one. Okay, we crossed off the pacifier. What do you call it with, and I'm sure you don't do this, Joshua, because you seem to be on point with your 3 youngins. But when a kid falls down, they don't immediately cry. They look up at the parent to see what their reaction is. And if they act like it's nothing and the kid's okay, is that an accurate statement? If so, what is going on there?
So we'll get to P&Q's question in a second here too. I think there's a reason why. I think there's a reason why we have like opposites attract chemistry wise in parenting. You typically have a very open parent, and then you also have a very assertive parent. I think are the two characteristics from psychometrics. So that one parent is very like, "Oh, honey, are you okay?" And the other parent is like, more pick up your cool points. Let's go. Come on, buddy. And kids do need both. And so chemistry wise, we're kind of attracted to a complementary partner sometimes, which is difficult because we don't really interpersonally connect perfectly, but it's for the benefit of the kids that we don't connect perfectly.
That's interesting. I like that theory.
Yeah. Well, I mean, it makes sense. Like we're not pairing off for our benefit. That's a very narcissistic way to look at the world. We're pairing off for the children's benefit. And so we have instincts for the children's benefit, not ours. So
what I was going to say is the research kind of affirms you want emotionally intelligent parenting. What they mean by that is like you want the kid to be safe to express emotion, but obviously that doesn't mean if the parent is panicking, I could imagine that'd be bad as well. But I will tell you consistently, there is consistent bad findings when the parent is like, get over it, brush it off. What do you got to complain about? Those are consistently related to bad mental health findings in kids.
Right. Yeah. And if you have, there's actually some pretty bleak studies on, single parenting, with temperament analysis of like, it's very easy to get kids that you can predict are just not going to have a lot of resilience. If you have a very open parent and they're the only person in the partnership, so they're very empathetic, the kid's just not going to get tough. And that's rough. You see, you have to have a counterbalance to that. I'm not saying that it's not good to be open. It is.
Uh-huh.
But you need a counterbalance to it. Like we're not sophisticated. You have two hemispheres. You need two parents. You got two halves of your brain. They're actually divided.
Yeah.
And so we actually need like two temperaments to balance that out. And that's complicated.
I like that. That's complicated. Yeah, it's true. P&Q's question about, is it good to train neurofeedback if I'm sick and tired?
No.
I'm not going to take it anymore. No, yeah.
There's a classic mistake that people make. I've seen it. Okay. I laughed it off. People will hook people up to neurofeedback and they'll be like, man, you've got a lot of theta today. Let's just add a filter in here to train down that extra theta. And then they just crash and get really sick. Well, that's your immune system ramping up. Don't train that down.
Now that P&Q says, what about if I'm just tired?
Yeah. So you're going to get less out of neurofeedback if you're just tired. Think about it this way. When's the best time to do neurofeedback? When would be the best time to go to school? That's the best way to orient yourself to neurofeedback. We try to schedule everybody kind of in the morning to early afternoon, and we try to schedule people less in the afternoon 1, 2, 3 p.m. Now, there are people who want those slots because they have interesting lives, and that is when they are most alert. But for their benefit, we're not being like, hey, you want to take my 5 p.m. We're not putting them in there because it's convenient for us. It is quite inconvenient to have less workable hours, and to, we have a client who is like, yeah, I work late and I wake up at noon. We're like, that's fantastic. We'll slot you in at 4. Like, this is great. You'll have a 4 p.m. slot. This is great for us because, we have to be conscientious of those variables for learning reasons. You'll just learn less. So tough responsibility if you want to take learning seriously.
Well, if you do neurofeedback when you're tired, it's basically more expensive. You're paying more per session, right?
Yeah. You're getting less for each payment, so you're going to have to do more sessions to get the same response.
Oh, Radar
message,
changing work schedule next week.
Send us the questions before. Radar. No, we won't. Send the questions beforehand. We'll read them off, Radar.
That's right. If you're going to watch it, Radar, absolutely email in the questions, and we will post them for you and answer them for you.
Yeah, man. Well, good luck with
100%,
work.
100%. Yeah.
He wants to share the link to the Neurofeedback Discord chat.
Hell yeah.
Yeah.
Share away, brother.
That's great. Yeah. So there was a really cool PTSD couple articles that came out, Josh, that I'd be curious what you think about veterans. Well, about 9/11 responders, one of them, and one about veterans. The 9/11 responder one was essentially it took some of them 10 and 20 years to recover. So that one, and that's that. But there was another really cool one, and it was called something like the PTSD training that all veterans wish they had, or something. And it described the main therapy for PTSD as apparently, or most research backed, is called prolonged exposure therapy.
Right.
And you're exploring your trauma with a therapist, and they say it can work. Actually, it probably works for most people, but it takes years, and the adherence rate, the compliance rate is low. People don't want to do it because it's, I think I'm recalling this, it's uncomfortable. It's uncomfortable.
It also probably isn't, the research probably doesn't reflect dissociative patients. I would suspect. I could be wrong about that. But I bet that when they, and I think this is common, but when you're doing research on trauma, like you're probably looking for non-dissociative PTSD. You're okay with complex and maybe chronic, chronic and complex, but maybe not dissociative. And I'd be a little surprised by that if it was. I've done exposure therapy with clients, and we really, you could think of it like sleep training.
Interesting. Okay.
There's a lot of ways to solve trauma, honestly, like a lot of ways, and the right way is the way that works. What's that?
I like that. Go on.
Yeah, the right way is the way that works. I personally love neurofeedback, but there's all kinds of reasons why people can't do that. I work a ton with people who've survived getting out of cults, and there's a few in our area where what they did involved, electrical devices, and they don't want the stuff on their head. And
what a timely question. We just got a question about Scientology. Sorry to cut you off, but you continue. Please continue, Josh.
Do you know anything about Scientology auditing?
Yeah, I love Tom Cruise.
Yeah.
And whether it's similar to EMDR. And no, it's not similar to EMDR from what I understand. Yeah. Extremely similar, really. Interesting. I didn't think it was similar, but I haven't really explored, what the Scientologists are doing.
Well, there's a really good documentary about it. I think it's literally called My Scientology Documentary by Louis Theroux. He's famous for going undercover with cults, and it's I saw it at the movie theater. It's a big documentary. Anyway,
we're gonna get Pete in trouble. He's gonna get doxxed by the Scientologists.
Oh, maybe, yeah.
Take a number.
Take a number, right? Go after everybody. So anyway, so he goes in and they have these sessions called audits that Radar's referring to.
Yeah,
and in the audits. So actually, what interesting thing is they promote Scientology as acting classes. So Scientology they're trying to get celebrities, and they figure if we can get them early, that will be better, because now I guess they're easier to come to our side or something, maybe like that. And so they offer them, come get free acting classes. And then when you go there, I don't know if it actually is an auditing class for Scientology or you can sign up for that. They actually, he says they actually own coffee shops in LA. They own coffee shops that you don't realize is a Scientology bureau until you see these pamphlets in the door. But anyway, an audit, like the first two he describes, the first one is you tell them everything about, they literally ask, what are you afraid of? What makes you insecure? What are your traumas? The second one, they hook you up to, it's basically a lie detector machine. Right. Maybe galvanic skin response, something to measure your stress level. And then they yell at you. They literally yell at you, and they berate you, and they say, you're just a failure because your father was a failure. But they're reading whatever you told them on the sheet. And the idea is that the goal is that you do not register this, your heart rate and your skin response do not change. So it almost is a form of biofeedback. And they will do this until you can stay centered. But it's also manipulative. And their real goal is to get you into the system. Yeah, go on, Josh.
Oh, sure. Yeah, when I could see that too. I could see their concerns. I think that with EMDR, there does sound some similarities. You're basically waiting for what's called an interweave. And advanced EMDR classes will talk about interweaves. It's not commonly taught, but it is part of the base advanced theory. Interweaves are where something that is very, very true about the world that exists for you now, that your brain is not connecting to your trauma. But if it did, your trauma would be ridiculous. So like, for example, you could be a successful entrepreneur or a parent or have lots of loving relationships. And whatever it is, whatever resource is what it's called. Laura Parnell's writes about this a lot. Whatever resource you have can be interwoven into your trauma. And this happens unconsciously or spontaneously in EMDR. What you're doing is you can ask somebody to go to something really absurd sometimes. And you can even play the villain even in EMDR and say like, okay, people are like, I'm afraid that I'm just like my mom. And it's like, okay, I want you to just entertain that thought. You're just like your mom. And the reality is that they're so avoidant of that they haven't even let themselves think about how that would even look. And if they did, they'd realize it's ridiculous. And then their real world would interject all kinds of truths that would almost poison that trigger. And that's kind of what an interweave is. It's almost like it's an interwoven truth that makes the trigger paradoxically nulled out. That's the only way I can describe it.
So,
but it works really, really well.
That's awesome. I'll do PNQ's question. I just want to say that the last PTSD article I read, though, was about there's a new therapy where you guys, if you have trauma, please do this with a therapist. This is not a recommendation, but I wanted to. This is clinical trials now at Cornell. Basically, they have you envision yourself in a movie theater. And not only that, you're in the projectionist booth watching yourself watch a movie of your trauma. So you're imagining your trauma's up on the movie screen. And if you've ever heard Tony Robbins talks about this, is because he got it from this Cornell professor. And there is one clinical trial done that's very promising. Essentially, they have you watch yourself watch the movie, so you're distanced from it, and you try to make the movie of your trauma, you're trying to make it funny, silly, or boring. So for instance, they tell you, zoom out, make it black and white, make it tiny, change the volume, the voices, add clown music. Do anything you can until, with the help of the therapist, by the way, that your heart rate is not going up, kind of like this procedure we're talking about, that Radar is talking about, that you are no longer feeling the same level of intensity. And people are saying that when they do this, they talk to veterans, and this was in the Atlantic, and it was at a psychology conference. They had all of these patients come up. They described that in 5 sessions, it eliminated their flashbacks doing this. They were having flashbacks. And there's a third part, just so you people, for completeness. The third part is, now imagine that instead of the traumatic event, the movie's different, and something different happens. It doesn't have to be just anything but whatever the trauma was. Maybe make something nice happen, make something funny happen, etc. So you're trying to heal that in a way. What you're really trying to do, they said, is change the associations of the memory so that the memory is triggering something other than pain for you.
Well, the reason why this works is because we don't really remember our trauma. We remember the last time we remembered our trauma.
Okay.
And so if you can interject something at a midway point, it stays there. And
cool.
and you can do all kinds of stuff to mess with it.
Yeah, there's there's a recent this year as well study that said if you play music, positive music, while thinking of your traumatic memory, it will change the associations in that traumatic memory. At least in this study, it won't be as painful for you anymore.
Well, that's a really mild reset mechanism. That's the whole concept behind ketamine. That's the whole concept behind the psilocybin reset. That's the whole concept behind the MDMA microdosing. That's what they're doing with that. But you can do the same thing with exercise, with music. If you can find a strong enough sensation, you can do it with anything. It's just like bring up the memory, which is going to have permanent associations, attach a lot of things to it, preferably things that are paradoxical to it.
Yeah.
And then sit with it until it gets confused or resets or paradox or gets a paradox. And then just see if you get triggered again later. Like, good luck. Now, I'm not telling people to go do that on their own, but the therapists do a really good job guiding people in that. Trauma therapists. There's actually a ton of ways that trauma therapists can walk clients through healing. What I tell my clients is I give them permission once they've solved something big in my office, that I give them permission to go work on smaller stuff at home by themselves. So I do give them permission to work on the smaller things. I just want them to bring the biggest thing to me. And once they've dealt with the absolute biggest thing with me, and they've demonstrated they can practice some small things at home, they graduate.
Yeah, I like that. It's like goal setting or something, SMART goals or something. I'm trying to think. P&Q is having questions. Well, first they say, this reminds me of memory consolidation and coherence therapy. And that P&Q, that's correct. The articles, this therapy I was describing was called memory reconsolidation therapy or something like that. But the next thing, P&Q was asking, how do I measure the Inyan? And I don't know if we want to ask. They got a bunch more questions, actually. So
we got the Inyan.
That. Yeah.
I love a good fried onion.
The Inyan. The Inyan is the ear, right? So, yeah.
I thought it was
Inyan. Yeah. It's like where your finger stuck on your ear.
The joint, right?
I thought it's the back of the head. Yeah.
You're thinking of the mastoid. Or no, that's the the Inyan. Maybe you are. No, you're right. The Inyan is the.
What I've heard is
a long week for me. The Inyan.
It's where you can't feel bone anymore, is what I recall.
Yeah, you're right.
I recall in the EEG manual here.
Oh, here's a good one. What happens when you watch videos or talk with someone while doing neurofeedback? Is boring neurofeedback more effective than more stimulating ones? Boy,
controversial. I like it. I do try to give my clients more boring feedback, though I don't think other practitioners are going to always agree with me. But I also don't try to give anxious kids boring feedback. So you have to think of it like a resource. Okay. Like I have to have the kid calm and focused. If I can get an adult calm and focused on something boring and keep them properly vigilant for 30 minutes, sure, I'll default to something boring. But if I can't, I'll kind of think carefully what I can use. And I have hundreds and hundreds and hundreds of programs that I can use, and I'll kind of use some skill in what I choose. So yeah, I think you have to be strategic. Indian is the back of the head. Thank you. Nasen's the front. Yeah, I don't know. It's been a long week. I apologize. It is Indian's the back. Can you train?
Well, that's why we got the help. This is, it takes a village, Joshua.
And guys, I found that I probably need to jump off here suddenly.
We're done. But, what's your group? What's your group?
Science and Technology Discoveries. You're good, man. I appreciate it. And thank you, Josh. And I learned a lot on these calls too. I appreciate everybody. Thank you.
Yeah.
All right. Thank you for showing up, Anthony.
Have a good
Joshua, let's push your book.
Okay. Well, Neurofeedback for All is designed to be a cheap introduction to neurofeedback. Neurofeedback for All, a beginner's introduction. You can get it for $3 for a Kindle edition and $21 for a print, and that's the cheapest Amazon would let me sell it for.
And $200 for the Audible version.
No, there's no Audible. There's no Audible.
Let's take care of PNQ's question. We'll split. Yeah.
Is it better to take breaks during neurofeedback or do 30 minutes straight or something? I think there's a lot of arguments for different ways. Currently, we kind of do. It probably does depend, because I could think of clients where I think there's exceptions. Generally, not including the exceptions. Probably.
Well, hold on. Isn't it like looking at the raw data and making adjustments? That's why I say depends. Or Pete, shut the hell up.
No. So it depends on your system. Some systems will calculate and reposition and give you different criteria every 2 minutes, 5 minutes, 10 minutes, or something. And those might have like a pause and then adjust and then do it again. I can think of a couple that work that way. But those are maybe very short intervals before they're restarting again. I think Brain Paint, for example, is one that does that. It's like physically pauses every few minutes. Really, yeah, the way we do it in our clinic is we just have 30 minutes straight. If we do have times where we'll stop it for different clients, but those are case-by-case situations where clients are prone to overtraining. We might set a timer. Yeah.
Oh, Saul, I missed you.
There he is. In the back. Yep. We do know this. It's just been a long day. We do know this.
Saul, why don't you join us every Wednesday on this side of the fence so we can have somebody? Because I think people like to hear Saul more than want to hear me.
For those who don't know, this is like the neurofeedback Bible, or at least one of them, like the evidence-based practices in biofeedback and neurofeedback. And Saul's here in the comment section, but he's also on the book that we use every day.
Saul is NRSB, right? Or Northeast Regional Biofeedback. He has the. Saul, if you were here, you'd be selling your program right now. Maybe put it in the comments here. So I'm going to reach out. Yeah, we need him as a panelist and his wife.
He'd be fun.
Oh, there he is. NRBS. That's what I said. Saul, PNQ, Radar. Who else did we have come in here? Hida, thanks for showing up. Jahan, thanks for showing up. Everybody, see you next week. Same bat time, same bat station. Peace out, Joshua.
Thanks, guys. Appreciate it.
All right, bye-bye.